You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today we're diving into an increasingly urgent and complex area of frontline medicine, that of psychoactive substances and synthetic drugs. So over the past decade, the drug landscape has shifted dramatically. So potent synthetics, unpredictable chemical variants, and indeed rapidly evolving supply chains are creating new clinical challenges for ambulance crews, HEMS teams, and frontline responders. These substances don't play by the traditional rules. Presentations can be extreme, toxidromes atypical, and responses to treatment unpredictable. So to help us understand this shifting landscape, I'm joined by Dr. Caroline Copeland. She is a senior lecturer in Pharmacology and Toxicology at King's College London, and indeed the director of the National Programme on Substance Use Mortality. Caroline is one of the UK's leading experts in drug-related harms, combining pharmacology, epidemiology, and innovative data science to help us really better understand emerging substances and their real-world impact. So she also advises on national bodies, contributes to the ACMD's Novel Psychoactive Substance Committee, and leads national surveillance programs shaping policy and practice. So today, she's really going to help us walk through and unpack what clinicians need to know, what's changing, and indeed how we can better protect patients in a rapidly evolving drug landscape. Caroline, welcome to the podcast.
Thank you very much, Owen.
It's great to have you with us. Caroline, I just wondered if we could just start by, I guess, a good baseline is really just getting a definition of novel psychoactive substances and indeed synthetic drugs. Could I get you to maybe just speak to that and what distinguishes them from more traditional illicit substances?
So a novel psychoactive substance to me and to many people is one that's either completely newly synthesized fairly recently, so a completely new drug, or it's one that has been known about for some time, but has only newly emerged on the illicit drug market. So I'm sure that you might have heard about the new synthetic opioid crisis hitting the streets in the UK. And these were a class of synthetic opioids called nitazines. And we would class these as NPS because they are new but some of them are newly emerging. So the nitazines, or really some of them, were first synthesized in the late 50s and early 60s. So they're old substances, but they just have a new emergence. What that definition, though, in other countries looks like depends really upon what your drug landscape is. So, we don't really have any of the Captagon, which is in sort of the Arab nations at the moment. So if that was to appear in the UK, we would class that as an NPS. But for them, they're like, oh, well, this is old news kind of a thing. So your interpretation of NPS is really dependent upon sort of the drug market that you're examining.
Yeah, indeed. No, indeed. And like you said, I used to work in Canada and actually there's extreme challenges there with fentanyl, but not just fentanyl, just with the toxidrome of what might be a very altered synthetic fentanyl, which was almost resistant to naloxone, and indeed, but we'll unpack some of these variants shortly. I guess my next question would be, Caroline, around your work at the National Programme on Substance Use Mortality. Could you speak to from working on these working groups, just the most striking trends you're seeing within novel psychoactive substances and synthetic use in the UK and or internationally? Are there any specific classes of synthetics that are on the rise in pre-hospital care or indeed emergency care?
So we're seeing a shift and the new drugs that are emerging on large are these synthetics, and I think that we're seeing drug gangs move away from plant-based drugs more towards synthetics. So your plant-based ones, your opioids, your heroin, your morphine, your codeine, and your cocaine, things like that, and more towards these synthetics. And I think a reason for that is, well, several reasons, but with plant-based drugs, you need land to cultivate them, you need good weather and water, you need farming equipment. They're also not very potent, so they're quite, you need a fair amount, so they're quite bulky to traffic and to move around without being detected. Whereas the synthetics are easily made in clandestine laboratories, and they're so potent that if you send 100 greetings cards with a gram each in them, some of those are going to get through the postal system. And so they're easier to make, they're cheaper to make, and they're easier to traffic and smuggle as well. So I think that's why it's one of the reasons we're seeing a shift towards a greater number of synthetics emerging. And in terms of the classes that we're seeing, the US has had a problem with fentanyl for several years at the moment, which is a synthetic opioid. And we're starting to see these nitazines in the UK as well. But we're also starting to see a shift towards some synthetic stimulants as well. So cocaine is a naturally occurring stimulant in the coca plant, but we're starting to see synthetic cathinones and other synthetic stimulants appearing. And I just think that's the trend towards where we're going. And many of these synthetics by design are very potent, which means that the dose of drug which is safe to take is much harder to judge, because you're looking at needing just a small amount to cause an overdose.
Yeah, indeed, indeed. And would I be correct in thinking, and this is maybe a street term, I definitely bumped into, I think, a synthetic cathinone recently. Was it bath salts? That was, or certainly the street name for the synthetic cathinone, but absolutely was creating an ABD kind of almost manifestation, acute behavioral disturbance, and it's very tricky to deal with. Certainly something which prompted a lot of research from me, because I hadn't bumped up against these synthetic cathinones before, but very difficult to judge the quantity and quality of any drug like that.
Yeah, so I think the term bath salts comes from when these substances were legal. So pre 2016 in the UK, in order for a drug to be made illegal, it had to be named in the Misuse of Drugs Act and controlled. But in the early 2010s, that's when a lot of these NPS started emerging. And by the time you controlled one, it had gone out of fashion and people had gone on to the next thing. And so it was this sort of game of whack-a-mole of trying to play catch up with the emerging substances. And whilst they were sold openly in what were known as head shops, they were listed as not safe for human consumption. And I think that's where the bath salts thing came from, as how they were sold. The other name I've heard for them, and I should probably Google this because I don't know why, is they also get called monkey dust as well. So, but I can't tell you the origin of that name, I'm afraid.
It is interesting. It is interesting. So something we just notioned towards earlier, Caroline, and I'd like to get you to speak to this if possible, was really the key challenges, because like you said, the potency is exponentially higher of these novel synthetic psychoactives, and then actually we are seeing a deviation from what we might know as like a classic overdose scenario and symptomatology. Could I get you to maybe just unpack for us just some of these deviations that you're seeing either in the research or indeed in practice that sort of are extremely challenging to manage, really, due to the potency?
I think there's two challenges here. So I think one is the potency. So the harm reduction advice that's given to people who use drugs is go slow, don't use alone, and carry naloxone. And that first one, that goes slow, you might go slow, but if something's incredibly potent, the small amount could still be a fatal dose. And so that makes it the other two so important in terms of don't use alone and carry naloxone. And I've never treated anyone with naloxone myself that's suffering an opioid overdose, but I've heard of reports of people who have taken nitazines in the past couple of years, that naloxone is effective against the nitazine overdose. But what might happen is the person might relapse into respiratory depression not very long after that initial dose. So they would need repeated doses over a more extended time frame than an opioid overdose from one of the other opioids that somebody might have taken. So I think it's important to know that it is still looking like it is useful, and naloxone is actually a really potent antagonist, so should still be effective. So I think the potency is one challenge with these NPS, but then the other one, which is a challenge for both the users and any healthcare workers that are then trying to treat these people, is actually knowing what it is that the person has taken. So, we have a few sort of drug checking mechanisms here in the UK where people can say, what drugs that they had intended to buy, and then laboratories will test them and tell them what actually was in what was purchased. And quite often it is what people expected, when it's one of the more classical substances like heroin or cocaine or ketamine. But when it comes to the NPS, very rarely do they actually know which NPS it might have been that they've intended to purchase. So, the nitazines are one example, spice compounds or synthetic cannabinoids is another. People might know the class of substance they've intended to buy. And even if they do have that class of drug in their sample, the nitazines range from being as potent as fentanyl to 50 to 100 times more potent. So within class of nitazine, there's this huge difference. And that's even if you're sold what you think you're getting, because you could be intending to buy one thing and be given something entirely different. And so that's a problem for a user to know how much to take, but then also for somebody trying to treat them. They don't know necessarily what's the best way to manage these people.
Yeah, indeed. No, indeed. So just pivoting and looking at red flags, actually, Caroline, and it's such in a way, it's such a difficult question to ask or indeed answer, because there's a whole spectrum of probably red flags. And to your earlier point, to the point you've just made, actually, especially with synthetic derivatives, which are extremely potent, you might deliver an administration of naloxone, which works now, but then might wear off in the future. And it's I guess in a way safety netting and thinking about how comfortable you are with ongoing treatment, but because it will always make me nervous, especially if you reversed indeed a fentanyl overdose and they didn't really want further treatment, indeed they might run off, and actually you think, gosh, what's going to happen in 5, 10, 15, 20 minutes time if that naloxone wears off. But I guess my question is really, are there any top of mind red flags or atypical signs that paramedics or HEMS crews should really have front of mind with novel psychoactive substances?
I mean, that's a really difficult question to answer, I'm afraid. In terms of an overdose, if someone is unresponsive, and you suspect opioid use, give naloxone is about the only advice we can really provide. In addition to respiratory support, and CPR if needed. I think the only other bit of advice in that regard could be that if the person doesn't want further treatment and wants to decline any further intervention, would be to try and at least give them some naloxone if that's possible at all to take with them, so they've at least got it either for themselves if needed, or if they come across a friend or a family member that might need it in the future. So it's difficult to say that there's a particular sign. It's just these people would have slipped into respiratory depression much more quickly than from a heroin overdose. But other than that, an opioid's an opioid in that regard, and that the signs and symptoms are going to be very similar.
So how would you differentiate, Caroline, just a first-time drug user from maybe more dependent drug user, from a drug naivety perspective, or indeed how you just might approach them per se?
It's very difficult to be able to know a person's drug use history, and indeed many people who use recreationally are very unlikely to actually consider themselves dependent users, even though they might be using every weekend, or maybe multiple times every weekend even. And getting somebody to actually admit their drug use history can be quite difficult to do. You're asking people to acknowledge and admit to what is an illegal activity. So and people have these perceptions as to what is a drug user, in terms that they might be using powder cocaine every Friday night, but they have a family at home and hold down a full-time job, so they wouldn't consider themselves a dependent user. So even within someone that's using drugs recreationally versus dependently, there's a lot of grey area between those things. I'd probably say that quite a lot of the population of dependent drug users have most likely come into contact with drug services or mental health services at some point in their life. And that's probably less likely for a recreational user. And I think the way to engage a recreational user the most is to not treat them as a drug user that's a criminal, but rather a person that is doing something that's fairly risky. And how can we make that situation less risky? How can we make that drug taking behavior safer? If someone's going to take the drugs no matter what, there's no point in sort of saying, oh, well, you're out on your own then. What can we do to make that safer? And that's through education programs and improving user understanding in that regard.
So, Caroline, we know that many overdoses and indeed deaths involve polydrug use and indeed complex contexts, as we've spoken before. From your research and indeed the data you've analysed, how big a role does synthetic NPS play when they're mixed with other substances? And indeed, should this be top of mind for sport practitioners?
Yeah, so polydrug use is a huge problem, and I think it's bigger than it's given credit for at face value. So looking at the database that I run, back in the early 2000s, the average number of substances that somebody had detected at post-mortem was between 3 and 4 substances. That today is up to 6 or 7 substances. And actually there was a case I was entering last week that had 24 different substances detected in toxicology. And these are people that are taking these substances in combination to try and tailor and tweak and augment the experience that they're getting overall. But in doing so, it's an incredibly risky practice. And equally, again, with some NPS substances, you might be buying what you think is a synthetic cannabinoid, but actually there might be 4 different synthetic cannabinoids in that preparation that you're giving. So you might think you're taking one thing when actually you're already taking 4. And that's before you've started taking anything else on top of that as well. So multiple stimulant use or multiple depressant use is risky for both cardiac and CNS function respectively. And we don't know that much about the pharmacology of these NPS as much as we do the classical substances. We don't understand what's called their pharmacokinetics, how long they last in the body, and their relative strengths, how are they excreted, all of these questions. And so in order to advise someone in terms of how would you treat it or how would you use drugs in combination with each other, that advice is really difficult to get because we just know so little about them. There are so many of these substances that are constantly emerging, and we know so little about their actual action, and that's really problematic.
Yeah, indeed. No, indeed. Let's just look at really around emerging technologies to assist services in really identifying or monitoring or preventing harm from synthetic drugs. So your group is developing wearable sensors and indeed analytics and novel tools. Could you just speak to maybe these tools and indeed whether there's any barriers to implementation or whether they're quite successful in their implementation?
So the one that we're looking at trying to develop is one that detects the concentration of opioid in what's known as interstitial fluid. So you might have seen the glucose sensors that people are starting to wear now, which are a tiny little electrode that goes into the skin, and it's able to measure the fluid that sort of bathes our cells. And I think the best way I can describe that fluid is if you've ever scraped your knee and that sort of sticky clear stuff that's coming out, that's your interstitial fluid. So that's what we're measuring drug concentration in instead of directly in a blood vessel, so to speak. And there's a few of these wearable sensors that are coming out at the moment. The one that I've heard the most about is one that measures your O2 sats, your oxygen saturation. And if that starts dropping, that could send an alert that someone's going into respiratory depression from overdose. But I think, whilst that's good to have that alert, if you're already dropping your O2 sats, it's already bad news and quite late. And by the time the ambulance has got to you with some naloxone, you've probably not been breathing for quite some time. So the one that we're trying to develop is able to detect concentration of opioid. And so what we are hoping to be able to do is if someone was to be seen to have a rapidly increasing concentration of opioid, to be able to send off that signal that help is needed sooner than you get to the point of O2 saturation. So, but it's quite difficult to develop these things. We've got the science side, which is the part I would say that I would know about in terms of the actual measuring of the concentrations of the drug. But then the whole other side of this is, well, how can we link that into geolocation of the patch? So you have Bluetooth, you could Bluetooth the results to somebody's phone as the glucose patches do, but then how do you interface that much wider? And that's the part that I know is possible, but I know very little about that part of the sort of device development. And so what we're looking at is trying to expand the types of substances that patch could be used for. So not just opioids, but other stimulants as well. Cannabinoids would be useful. Other things like benzodiazepines, street benzodiazepines would be incredibly useful for. And it wouldn't just be useful necessarily just to for someone to wear to alert emergency services to. It would I've had some psychiatry colleagues say it would be really useful if someone's come into A&E and they're acting quite erratically and you're not able to get a blood sample from them. If you could just whack one of these patches on their back and sort of put them in a safe room and sort of then get the readout of what it is that's actually circulating in their system, that might be quite useful as well. So I think there's potentially multiple uses for it.
So just pivoting slightly, Caroline, looking at policy, you sit on a number of advisory councils really and subcommittees. Could you get to speak to the changes in regulation and if there's anything that really, I guess in a way, pre-hospital clinicians should be aware of around regulation and the evolving drug market?
Oh gosh,
It's a big question.
Interesting question. So we're not winning in terms of drug policy and emerging substances. The whole reason that the Psychoactive Substances Act was introduced in 2016 was in an attempt to try and stop the rapid emergence of NPS, because so many were appearing that they couldn't be controlled quick enough before people had moved on to the next one. But since the Psychoactive Substances Act was introduced in 2016, we've not really seen that much of a reduction in NPS, to be honest. And so the money that can be made from people selling these drugs is clearly a greater motivation for doing this than the fear of the penalties of if they get caught. And I think that we need to be shifting our focus. And I'm not saying we should decriminalize all drugs at all points. I certainly think there still needs to be an effort, particularly for manufacture and supply, maybe less so for possession. But in terms of people who are using drugs, if we can reduce the demand for them, then by default, there's going to be less supply if you've got a lower customer base. And so we need to be looking at why is it that people use drugs? And I think, again, can we class people as recreational users and dependent users? I think for the dependent users, getting them the help that they need, very often there are underlying reasons why they are using drugs. It's not because they're doing it for fun. They're doing drugs to escape from some horrible reality that they're faced with, be that, past trauma or current situation in terms of, if they're experiencing homelessness or incarcerated in prison. And if we can address the underlying drivers for the drug use, I think we would hopefully be able to help some of the dependent users. But then when it comes to the recreational users, these are people that enjoy using drugs because they like the feeling of taking them. And I think it's going to be much more difficult to say to them, look, X, Y, Z, these are the bad reasons for you using drugs. They know that using drugs is bad and not good for them. But they do it anyway because they like them. And so I think we also have to realise that we're never going to stop people from using drugs, but we can hopefully make that drug use safer.
Yeah, absolutely. Absolutely. So just pivoting and looking at, we've spoken earlier about regional and global variation. And if I could just, because you do have quite a wide scope of visibility, Caroline, into the regional variation of NPS and synthetics, urban versus rural. But could I get you to speak to sort of if you do see any sort of variation, so to speak, within the UK or indeed mainland Europe? Do you see it more centered around sort of urban sort of cities, or indeed is it more widespread in the rural regions?
So, in terms of sort of where UK sits within Europe with regards to NPS use, we're certainly the sick man of Europe in that regard. I don't know why, but for whatever reason, we seem to have a larger problem with drug use than a lot of European countries do. I don't know if that's, a cultural thing from our perspective, or that when we're not as good as at educating or treating our citizens as other European countries are. I think that's it's a whole podcast in itself, I think. So we certainly seem to have a larger problem with NPS than a lot of other European countries do. Not saying that they don't at all, but we seem to have a bigger one. And in terms of regional differences within the UK, we certainly have more users and deaths in cities than we do in rural areas, but that's because just of the rules of population. If there's more people, there's going to be higher prevalence of things happening. But in terms of what we're seeing and where and why, it sometimes appears a bit random and a bit strange. And I think that really drills down to which drug gang is operating where, what their connections are with, and as to why we see certain substances. So, we were talking about the bath salts or monkey dust earlier. We don't really see them across the UK, apart from in Stoke-on-Trent. Massive problem with bath salts in Stoke-on-Trent. Why? Difficult to say why that they're so available there and not elsewhere in the country. I don't think there's a particular demand from the people of Stoke-on-Trent for them, but that's what's being offered on the streets. And equally with the nitazines, the one of the first bigger incidences of where overdoses were being seen was in Birmingham in 2023. And again, why Birmingham in particular and not another country and not another part of the country? And so it doesn't seem to be very predictable as to where we're going to see what and why.
Yeah,
Which
yeah.
I'm sorry is not very helpful from an emergency first responder situation. If and anything could be appearing anywhere at any time, but that's
Oh, it
pretty much.
is. It is what
I'm
it
sorry.
is. It is what it is.
Yeah.
Absolutely, it is what it is. So just coming to land, Karen, a couple more questions. One would be really around educational gaps, really that may exist within post-sport practitioners' sort of knowledge, because it is an evolving landscape, as we were saying before, and things do change quite rapidly, even around, like you said, drug supply, usage, regional usage. But could I get you to speak to any sort of short training modules or indeed training packages that you know of for pre-sport staff that might really, in a way, innovate them and indeed bring them up to speed for this evolving landscape?
I've actually been asked this question recently by some people in the uh, Royal College of Pharmacists as well, as where could I direct some of their staff to sort of learn more about NPS. And I don't think there is, to my knowledge anyway, and by all means, if there are any listeners that do know, please do post and let others know. But in the UK, I'm not aware of any specific training module. And I was actually in discussion with another colleague about maybe we should, think about creating such a thing. I think in the interim, one of the best things that I can recommend is if you were to sign up to the drug science webinars. So they cover emerging themes in the drug landscape with a webinar, either I think it's once a month, and they bring together a group of experts to talk about various different topics. So I'd recommend giving that a listen.
Awesome. Yeah, we'll signpost that in the show notes, actually. That's fantastic. Absolutely fantastic. Just finally, Caroline, as we come into land, just looking at the future, the next 5 to 10 years, could I get to, we've spoken about wearables, which are absolutely fascinating, actually. But could I get to speak to any other developments really in the field of novel psychoactives and or synthetics that you anticipate, or indeed in a way that gives you hope, really, because it is a shifting landscape, and like I said, there's absolute exponential risk in a lot of these potent drugs. But is there any developments that kind of give you hope in the next 5 or 10 years?
Well, there are things that we could be doing that I would hope that we could start doing more of. And I think there's a lot of reticence within elected officials for either of these initiatives because they might be seen as encouraging drug use when they're designed to make drug use safer. And there's quite a bit of evidence from other countries where they've implemented these initiatives to show that they do reduce drug harms. And those are to have easy access to in-person drug checking facilities. So that's where somebody can go in with a sample of the substance that they've purchased and get it tested and then be told what it is that they've actually got. And then they can make an informed decision as to whether or not they still want to take it or not. And we don't have any of those in-person facilities here at the moment. We've got the post-based program Wedinos, where people can post in a sample, and then a week or two later, it goes up online as to where it was purchased at the first half of the postcode and what it was that was purchased, along with a picture, so you can identify what you might have posted in. But most drug users aren't going to wait a week or two to see what's going on. So we need that really to be implemented. And then the other one is overdose prevention centres. So we have the Thistle up in Glasgow that was opened earlier this year, which is a safe and equipped space with qualified members of staff where people who would like to use drugs can go and do so in a safe environment. But that has been very politically contentious for a lot of reasons, that the residents around the area aren't particularly happy about it. And as far as I'm aware, I can't remember if it's 2 or 3 years they've been given to show sort of the impact that they have had by operating this centre. But until that review is delivered and investigated, I don't believe that any further overdose prevention centres are going to receive a licence.
Listen, that's really helpful. And so what we'll do, I just want to say thank you, Caroline. We'll put in the show notes the links to actually your landing page actually in King's College London, because there's actually some really, you've published some fantastic papers actually on your landing site. So there's some great empirical research there which you have published, and so we'll put that in the show notes. It's really interesting read for listeners, and we'll also put links to the suggested educational content that you mentioned as well in the show notes. But listen, just leaves me to say thank you. It's great just to touch base and indeed get some of your received wisdom on this topic. So thank you.
Great. Thanks very much for having me.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.